Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Craniopharyngioma, Current Evidence for Surgery, Medical, and Radiation Therapies, is being presented by Dr. Zachary Litvack. Dr. Litvack is co-chair of Neurosurgery and director of skull base and endoscopic neurosurgery at the Swedish Neuroscience Institute in Seattle, Washington. He completed his Bachelor of Science in Bioorganic Chemistry, Molecular Biology, and medical degrees at Brown University. Dr. Litvack then moved to Portland, Oregon to attend Oregon Health and Science University, where he completed an internship in general surgery, residency in neurosurgery, and a master's degree in clinical research from the NIH-supported Oregon Clinical and Translational Research Institute. Following his general neurosurgery training, he spent an additional year in pituitary surgery and Neuro-Endocrinology under the direction of Dr. Edward Laws in Boston, Massachusetts. Dr. Litvack has performed over 300 pituitary operations and participated in over 600 endoscopic endonasal operations in his career. He has been an invited presenter on endoscopic skull-base surgery at multiple universities, hospitals, and international conferences. At Swedish, he trains one neurosurgical fellow each year in skull base and minimally invasive cranial surgery, including pituitary surgery. Dr. Litvack, thank you so much for your involvement with the PNA's webinar program. There's going to be a brief delay as we change presenters. You should see on your end to accept.
Good morning, everybody. Can you see and hear me okay?
Yes. I can see you and hear you. Perfect.
Great.
Let's
get started. I'd like to thank the Pituitary Network for their commitment to educating both patients and professionals. It's my pleasure to be here today. And we're going to be talking about craniopharyngioma and current evidence and best understanding of how to manage what I think is an incredibly fascinating and complex disease. I have no disclosures relevant to the material here, but we will be talking about some use of either unapproved devices and drugs or off-label use of devices and drugs. So I do need to let you know about that. And I just want to remind everybody of why we're all here. It's because we love this little organ right here, the pituitary, which is about the size of a pea and is just 3/100ths of the percent total volume of the brain. And in just this one little area, along with the hypothalamus above it, which we'll be talking about in a little bit, this area is what regulates your body's response to stress, regulates growth and development, regulates blood pressure, body water volume, and salt content, overall regulation of your metabolism, function of your sex organs, both during puberty and for reproduction, and then helps to regulate the cycle of pregnancy, childbirth, and lactation. So a pretty remarkable little piece of neural tissue. And just to review some relevant anatomy, which we'll be talking about as we proceed, this is on the right here, a little cartoon zoomed in on this region of the pituitary. And despite its small stature, there's very complicated regional anatomy packed into a very small area. And so, as you may or may not know, the pituitary is actually divided into an anterior and a posterior gland. And this is important both in terms of development of the gland, but particularly for craniopharyngioma in the origin of the tumor themselves. Above the gland, you have the floor of the third ventricle, which is a portion of the brain that's filled with spinal fluid. And in that region, you have the hypothalamus, which is basically the central processing unit for the pituitary. So that's what tells the pituitary to tell the rest of your body how to regulate different hormonal activities. Similarly, in that same area is the optic chiasm. This is where the two nerves for vision come together prior to entering into the brain. And then the mammillary body, which is part of the memory circuit, so very important in formation of new memories and cognition. And we're going to keep coming back to this regional anatomy because this is tied in with a lot of the frequent presentations, symptoms, and potential complications of developing one of these tumors and the interventions that we're going to use to try to manage these tumors. So craniopharyngioma is anywhere from 2 to 5% of all adult brain tumors. And the reason for this range is that it varies geographically and by heritage. So for example, there's a much higher prevalence of this tumor in people of Japanese Asian descent. It's a higher proportion of pediatric brain tumors, up to 10% of pediatric brain tumors. And it is actually more than half of tumors that occur in this region of the brain, what we call the suprasellar space. Sellar being the portion of the skull where the pituitary sits. So tumors that sit just above the pituitary, more than half of pediatric patients who have a tumor in this area on the differential will be craniopharyngioma. There are about anywhere from 1/2 to 2 new cases per million people per year worldwide. So not a very frequent tumor, and an even distribution between male and female genders. So there's no predilection for one sex over the other. Interestingly, this tumor has what we call a bimodal age distribution, meaning that there are 2 peaks for when these tumors tend to present. There's a pediatric peak, anywhere from 5 to 15 years of age, and then there's an adult peak, anywhere from 45 to 60 years of age. So what is a craniopharyngioma? First of all, it's a benign tumor, and we'll get into that a little bit more shortly. And it's centered around the pituitary. It can vary in its exact location, and we're going to go into that in a slide later on. And it is a benign tumor, so that's the oma there, as opposed to carcinoma, which would be a malignancy. And it's derived from a structure, an embryologic structure called the craniopharyngeal duct. So craniopharyngioma literally means benign tumor of the craniopharyngeal duct. And there are 2 histologic subtypes. There's what's called an adamantinomatous, and that can occur in both pediatric and adult patients. And then there's a separate subtype of tumor called papillary, which only occurs in adults. Adamantinomatous is a mouthful. Quite literally, it means something that is like or derived from tooth enamel. So if we talk about the development of the pituitary gland, this is a little cartoon diagram, and it's a side view. And starting in the upper left and marching across down to the lower right here. And during development, the pituitary gland is actually derived from 2 different sets of tissue. It's derived from the epithelium of the roof of the mouth, and then it's also derived from a portion of what's called neuroectoderm, which is the layer that gives rise to the nervous system. And so what's being shown here is what's called an invagination, or a pouch that forms in the roof of the mouth called Rathke's pouch. And you may have heard that name before if you've done any research or may have this condition or done any of these webinars, that there's a condition called a Rathke's cyst, which is a benign cyst where this pouch doesn't completely involute. And so craniopharyngioma is often thought to be related to Rathke's cysts in terms of the spectrum from completely benign to more tumor-like. And over time, this pouch disconnects from the roof of the mouth. That's what's being shown here. This connection, this hollow, is the craniopharyngeal duct. And so this duct forms, leads into this pouch. The pouch pinches off and separates from the roof of the mouth, and then gets embedded in the base of the skull. So the anterior pituitary gland, which we mentioned earlier, is derived from tissue from the roof of the mouth, and the posterior gland is derived from true neural tissue. And they wrap around each other and form this functional unit where the anterior gland gives rise to certain hormones, and the posterior gland, or the pars nervosa, gives rise to some of the other hormones. And as I mentioned, remnants within this cleft can continue to secrete fluid just like the roof of your mouth does, and that forms a cyst. Or this epithelium of the duct can transform and form a tumor. As I mentioned, there are two subtypes. There's the adamantinomatous nominus and the papillary, both of which are considered grade 1 tumors by the World Health Organization. And the adamantinomatous is derived from the precursor cells that form teeth, specifically the enamel of the teeth. And that is part of the reason why these tumors have a tendency to calcify. So when we look at these on CT scans or even x-rays of the skull, we'll see calcium deposits, and it's one of the very convincing and consistent signs that this may be a craniopharyngioma. Papillary subtype, which again only occurs in adults, seems to be derived from the primitive cells that form the mucosa, or the lining of the mouth, which don't calcify. And the papillary is a description of this frond or gland-like structure that we see under the microscope, which is very characteristic of mature mucosal cells. Now, what's interesting and relatively new in the last 5 to 10 years is that we've identified very consistent gene mutations that lead to one versus the other cell type. And this isn't quite in standard of care yet, but may provide a target for some chemo or medical therapy, which we'll talk about later. So there's this CTNNB1, or a beta-catenin mutation, that leads to the adamantinomatous subtype, and that's seen in more than 95% of these tumors. And based on bench experiments, this is a driver mutation, which means that this mutation in this gene is enough to drive cells in a lab to form a tumor that's very similar to the one we see in people. The papillary subtype, the adult subtype, has this BRAF mutation, and the reason that's important is that this mutation is a mutation in a tumor suppressor gene that we see in other types of cancers. So for example, melanoma and some lung cancers share this BRAF mutation, and we actually have chemotherapy agents. We have targeted tyrosine kinase inhibitors that can block the activity of this mutation, and has been used in a couple of cases. It hasn't been studied formally in a randomized trial, but has been used to treat papillary craniopharyngioma in patients with very dramatic results. So that's something that's very exciting and hasn't quite hit prime time, but we're looking forward to in the future. Going back, I mentioned that these tumors can occur anywhere along this ultrastructure that we were looking at earlier. So this is that same close-up view where we're looking at the anterior and the posterior pituitary. We have the remnant of Rathke's cleft here, the infundibular stalk, which is what connects the pituitary to the hypothalamus so they can talk to each other. Hypothalamus is located up here in the floor of the third ventricle. And where this line is the diaphragm of the cella. So there's a membrane that separates where the pituitary is from where the rest of the brain and the spinal fluid is. And anywhere along that interface between the anterior and posterior gland, you can have tumors form, but depending on where the craniopharyngioma forms, they have different clinical characteristics. So the most common area is forming in this neck where the top of the anterior gland is wrapped around the infundibulum or the pituitary stalk. And then the second most, but less common, is to have tumors down lower, basically in the same region of a Rathke's cleft cyst, that can lead to a purely intracellular presentation. And then the least common is up above where the anterior gland is in the floor of the third ventricle, and that can give rise to this configuration where the tumor is purely within the third ventricle. And if you look on the scan, the pituitary actually looks totally normal in that case. The presentation for these tumors is different in different age groups. So in the pediatric age group, the two most common presenting symptoms are related to either deficiency in their pituitary hormones or a presentation related to hydrocephalus, which can lead to increases in intracranial pressure and development of headache, development of nausea or vomiting, and then gaze problems, especially in pediatric patients. They can develop difficulty looking up, or what we call an up-gaze palsy. The adults, on the other hand, typically present primarily with visual dysfunction first, because as adults we're much more visual creatures and able to express it. And if we go back over here to this slide, again, here's the optic chiasm sitting right here. So you can imagine if there's a tumor growing in this region and starting to compress it, as an adult who's very attuned and able to express themselves, you may be able to describe very quickly, you know, something is off about my vision. You can get diabetes insipidus from posterior lobe dysfunction, and this is a much wider range, anywhere from 15 to 30% of patients will develop this. And then finally, you can develop cognitive and memory problems. Some of this may be related to the endocrine dysfunction. Some of it may be related to the diabetes insipidus and some changes in serum sodium. And then some of it may be direct compression of critical structures. So again, going back here, this hypothalamus, back here we have the mammillary bodies, which are important in formation of new memories. And so again, if you have a tumor that's compressing, stretching, involving, or otherwise distorting this area of the brain, you can have direct compression of the tracts that are involved in formation of new memories. For the patients that do have an endocrine problem, the most common problem is a deficiency in growth hormone. And we see this in about 75% of patients with craniopharyngioma, that they have some growth hormone dysfunction. And depending on whether you're a pediatric patient or an adult at the time of presentation, these can present very differently. So prior to puberty and prior to your final set of growth spurts, lack of growth hormone can result in both a failure to thrive and a short stature. And so in especially young kids, say less than age 10, what this will present as is falling off their growth curves as they have their annual checkup with their primary care practitioner. With adults who've completed their growth stages and development, typically growth hormone is lack of growth hormone is primarily associated with fatigue. The next most common deficiency is in follicle stimulating and luteinizing hormones. So these are the two hormones that regulate function of your sex organs, so your ovaries or your testicles, and the production of estrogen, progesterone, and testosterone. And prior to puberty, this can lead to a failure of sexual development. And after puberty, this typically results in a loss of libido, impotence, and/or infertility. Then less commonly are deficiencies in thyroid stimulating and adrenocorticotropic hormones. So lack of thyroid stimulating hormone means your thyroid gland neither produces enough nor secretes enough thyroid hormone. And this has significant metabolic impacts and also some structural impacts in terms of the health of your connective tissue, especially your skin and your hair. A lack of adrenocorticotropic hormone, which is what tells your adrenal glands to produce and secrete cortisol, typically will result in fatigue and hyponatremia. And this is a common deficiency. Cortisol deficiency is commonly seen in a multitude of pituitary issues. Finally, a lack of vasopressin, which is produced in the posterior or the neural pituitary gland, as opposed to these other hormones which are produced in the anterior gland, can result in diabetes insipidus, which is a situation where your body does not concentrate or lacks the signaling and ability to concentrate your urine, and so you actually lose too much free water in your urine. That results in your sodium levels in your blood going up because you volume contract as a result, and significant swings in sodium can be life-threatening. Related is the hypothalamic syndrome. So this previous set of symptoms is due to dysfunction of the pituitary gland itself, but given where these tumors can grow or the development of hydrocephalus as a result of having these tumors, you can get dysfunction due to disruption of this region of the third ventricle, which again, just like the pituitary gland, relatively small physical area, but highly complex in terms of regulating basically all of the non-voluntary functions of your body in terms of what we call homeostasis, or maintaining itself. So disruptions in the hypothalamus, either due to the tumor or due to an injury from surgery, which we'll talk about later, or radiation effects. One of the most common presenting symptoms is obesity due to a lack of the ability to regulate and sense when you're full and when you're hungry. Sexual, both developmental of gender and reproductive function, is highly sensitive to hypothalamic disruption. This is also the area that's very important in regulating your sleep-wake cycle. So damage in this area can result in insomnia or poly or hypersomnia, meaning too much sleep. Even without damaging the pituitary, if you damage certain nuclei in this area, you can have complete pituitary failure because the brain can't tell the pituitary what to do anymore. This is also an area that's involved in temperature regulation. And then finally, there are behavioral and social issues that can arise from thalamic dysfunction, especially issues with depression or aggression or rage, which often results in social emotional withdrawal or ostracism. So protecting the hypothalamus is one of the key deciding factors when we're trying to figure out how we're going to address these tumors in terms of surgery versus radiation versus a combination therein. Because of all the things that can happen as a result of treatment, hypothalamic disruption is by far the most deleterious in terms of people's quality of life and overall survival after management of one of these tumors. So let's talk a little bit about overall survival. As I said, these are benign tumors, but they are very tenacious. It can be difficult to completely resect them. They have a tendency to recur, especially the cystic forms. And because of how compact an area we're dealing with, any growth or recurrence can cause significant shifts or changes and result in medical and hormonal issues. So if you look at patients who are under the age of 18 at the time of diagnosis, overall survival for a 5 to 10 year range is pretty good. When you look out 20 years, that tends to drop off. to about 62% survival at 20 years, and that's usually due to delayed medical complications as a result of the hypothalamic and hormone dysfunction. People who are adults at the time of diagnosis, if you look at all comers, the ranges overlap, but the survival looks a little bit better at the 10 and 20 year time perspective. So let's switch gears. We're going to talk about treatment now. And the first question that I want to address today is, what is the role of surgery in managing these tumors? And basically, since they were first described and then first addressed surgically in the early 1900s, the central tenet of treatment for these tumors has been a maximal safe resection. So initially, before we had radiation therapy, before we had some of these other adjuvant therapies, really the only treatment was to try to get what's called a gross total resection, or meaning completely removing the tumor. And over time, that's transitioned to what we call a subtotal tumor, and a lot of this is driven by involvement with the hypothalamus and not wanting to disturb that with a surgical trauma. And over here on the right here is a survival plot. So at time 0, everybody's surviving. And over time, we're looking at just progression-free survival. The top curve here is an incomplete resection. The bottom curve here is a complete resection. And this is without any radiation. And so even just without any radiation, it actually, overall survival leans towards doing a subtotal resection. And again, that comes back to minimizing the negative effects of surgery by avoiding portions of the tumor that are invading or adherent to the hypothalamus, so much so that taking them out would damage them. In the last 10 or 15 years, one of the big arguments has been addressing this via craniotomy, meaning an open surgery, versus doing this endoscopically, and we'll talk some more about that. Surgery also plays a role in the management of cysts. So sometimes these recurrent cysts, we can't remove them, but we can drain them either surgically or stereotactically, meaning with a needle, or sometimes we'll actually implant a reservoir, which we'll come back to, but this is basically a port that allows us to either externally drain the cyst, or sometimes even put some medication or other material into the cyst to try to treat it and get it to go away. And then lastly, especially in pediatric patients, if there's hydrocephalus or a disruption of the circulation of the spinal fluid that causes it to build up and increase pressure inside the head, surgery plays a role in terms of placement of a shunt. And aggressive management of hydrocephalus is important because we know that cognitive development in kids can be relatively normal as long as hydrocephalus is addressed quickly and definitively. But if there's a delay to management, or it's a recurrent problem that's undertreated, that can lead to significant cognitive developmental decline for children. So here are some cartoons of a craniotomy, and here we've outlined both where the incision is, so that's the dotted line, and then where the opening in the skull is, that's this gray line with these little circles representing holes that we place into the bone to start the cuts. And when we do that, we approach under the surface of the brain, which is this pinkish area here, and we come down right on that area called the optic chiasm. So this yellow, we're looking at the right optic nerve. Here's the yellow of the chiasm, and then the left optic nerve over here. Right next to the optic nerve from this particular approach or trajectory is the internal carotid artery. And then underneath it is this brownish sort of oil-colored mass, which is the tumor. And these green arrows are to highlight the corridors that we have to work through from a craniotomy approach to try to address this tumor. And that's shown over here on the right. This is an actual intraoperative picture where this glistening white is the optic nerve stretched over the surface of the tumor. That's what the yellow or the white arrow is pointing to. Here's the internal carotid artery. This white here is the oculomotor nerve. And so there's another corridor between the carotid and the oculomotor nerve to get to the tumor. But this is a very constraining approach. And so the alternative that's been used for a long time now, and certainly one of my favorites if we can do it, is this endoscopic endonasal approach. So this is a 3/4 cutaway view showing this trajectory from the nasal aperture down here. And it's a direct shot about 8 centimeters back to get straight to where the pituitary gland is. And we can get there without having to manipulate or disturb any of the brain structures or the internal carotid artery. But most importantly, in my and most surgeons' opinions that address it this way, is that this is the view that you get of that same area. So now we're looking dead on at the optic chiasm, that's the CH here. So here's the right optic nerve, here's the left optic nerve, here's the pituitary stalk. The pituitary is down here below the view of the endoscope. But we're basically looking up at the tumor from underneath the optic nerves as opposed to looking down on the tumor from above. And that means that the last thing that we see and or manipulate is the optic chiasm. So I want to show you a case example of one of my patients. This was a 59-year-old male who presented with 1 week of altered mental status and had this large cystic mass centered around the pituitary and the third ventricle. So here's the side view. This is a front-on view here. The ventricles are large, so this is big enough to cause hydrocephalus, but it's also big enough that it's probably directly compressing the mammillary bodies and some of the other structures involved with memory and cognition. And so the initial treatment for him was to place a ventricular drain, which is basically an external version of a shunt to treat the hydrocephalus. And then we brought him to the operating room to approach this from an endoscopic approach. I worked with our neuroendocrinologist to test him beforehand. He was deficient in a number of pituitary hormones, which we replaced before surgery, which is very important to make sure that your body can cope with the physical stress of general anesthesia and an operation. So we always want to know before surgery, no matter how urgent it is, what hormones we need to replace. And sometimes we will supplement them even without testing, just to make sure that there's enough hormone on board, primarily for cortisol and thyroid hormone, and make sure the sodium is regulated before putting somebody to sleep. These are just some other views of the mass. And here's the intraoperative video. This is about a 3.5-minute video that I'm going to walk you through. And so this is arachnoid, which is a layer deep to the dura. The dura has been open. That's this cut edge shown here on the right. You can see the dural flap. We're above the pituitary gland. That would be down here. You can see some of the calcifications in this tumor. And so this is just a blunt instrument to start to dissect some of this tumor. This is a suction tube to keep the field clear and dry. This is a device which uses a vacuum to aspirate or suction some of the tissue in and then guillotine it or cut it so we can take small pieces out. And this is a way to very quickly remove tissue from portions of the tumor. And we're going to punch through the solid portion into the cyst here. I want to point out this is the pituitary stalk right here. So we're actually able to separate the tumor off the side of the stalk and leave the stalk attached to the hypothalamus on the patient's left side. Now we're working above the tumor. This is in the region of the floor of the third ventricle. And this tumor had pushed up into the floor of the third ventricle, but it hadn't actually violated the tissue of the floor of the third ventricle. So this is a cautery device. So we're going to use electricity to cauterize or coagulate some of this tissue. so that I can sharply separate the floor of the third ventricle off the roof of the tumor. So here's a pair of scissors. And just to put everything in perspective here, the tips of these scissors are less than 1 millimeter in size. So these are very, very fine instruments, and everything's been greatly magnified with the use of the endoscope. Once we get that separated, we're able to peel the tumor off some of the surrounding structures. This is the basilar artery, one of the other arteries that feeds the brain, with some of its branches coming off and communicating. And so behind the basilar is the brain stem, and underneath the top of the tumor here is where those mammillary bodies are. So we're looking past the pituitary. This is the stalk here again, that tissue that's getting stretched but still attached, and using a combination of blunt and sharp dissection to separate it. And here again, using scissors to carefully dissect tumor off what is still normal brain surrounding it that hasn't been violated or involved. So here's the last bit of separating the floor of the third ventricle off the roof of the tumor. It doesn't always go this smoothly. Not infrequently, the tumor has invaded this tissue, and sometimes we're left with a hole in the floor of the third ventricle when we're done resecting. But here's the bulk of the tumor coming out now. And here's that floor of the third ventricle still intact. That's pulsating the spinal fluid. And then underneath the cottonoid here, so this is just a piece of cotton used to dry things off, you can see the basilar artery and the brainstem. And so this is an example of it going about as good as it can ever go with an endoscopic surgery. And so this was somebody where we were able to achieve a complete resection. And he did recover some of his pituitary function, not all of it, but we were able to cut his dosing in about half, so he's not completely dependent on pituitary replacement. So there's been a lot of studies looking at transcranial versus endoscopic approaches. In terms of the ability to achieve a gross total resection, it's an overlap, but it tends to cluster a little bit closer. So about 65-70% of the time, for a case that is carefully chosen to be done endoscopically, that means that 2/3 of the time we can get a gross total resection. With transcranial approaches, it's more difficult, oftentimes because we're addressing tumors that are much more sinister, much more invasive. And so whether you did it endoscopically or transcranially, you'd never get a gross total result. The incidence of diabetes insipidus tends to be a little bit lower in the endoscopic series, but the issues with spinal fluid leaks after surgery tends to be higher. I think what has been the most dramatic improvement is people's visual results after surgery. So in the transcranial surgery, only about 1/3 of patients have their vision improved, whereas in the endoscopic series, it's anywhere from 2/3 to 3/4, with a much lower incidence of visual deterioration. So that's probably the biggest driving factor in our choice of approach, aside from the technicalities of it, is that we do a better job preserving and improving vision when we take that transnasal approach that brings us in underneath the optic nerves, so we're manipulating them less during the time of surgery. I mentioned earlier, sometimes these tumors can form cysts. So here's an MRI showing 2 large cysts. And especially in very young children, we may choose this where there isn't a big solid component. We may choose an approach where we treat just the cyst as a way to delay the time to a definitive surgical treatment or to radiation. And so this still requires an operation to place the Ommaya reservoir. So there's a catheter that goes through the brain into the cyst, and then there's a reservoir, which is like a chemotherapy port that sits under the scalp. We can use that to drain the cyst, or we can instill agents to try to get the cyst to shrink. So some places use a radioactive isotope of phosphorus, P32, and this is a one-time treatment. And the series from the groups that do this say that anywhere from 80 to almost 100% of cysts will regress, but they use that term very loosely. So that doesn't necessarily mean that the cyst disappears. And that it could include that the cyst stops getting bigger. And this can take months to take effect. The other two agents, one is a Bleomycin, which is a cytotoxic drug, and about half the cysts will regress. What's interesting is that there are a number of centers that use this routinely and believe in it, but when you look at all the evidence put together, there really isn't a lot of convincing evidence that this is effective in terms of being a good standard of care. More recently, we've been looking at a chemotherapy agent, interferon alpha, which is a 4-week course of treatment. And that's been studied a little bit more convincingly, where more than 3/4 of cysts will shrink by half or more in response to this treatment. Now, these are temporizing measures. It doesn't stop the solid portion of the tumor from growing, and it doesn't always control the cysts. So the average delay time is anywhere from 12 to 14 months with a larger range. But especially for young children, if we can delay the need for radiation, which can have an impact on brain development and cognitive development, that can be advantageous. So let's talk about radiation, and we're going to wrap up talking about radiation and then have some time for questions at the end. The way that radiation works, regardless of the modality or the device that's used, is it delivers energy either in the form of waves or particles that break DNA, cause a double-strand DNA break, which is very hard for a cancer cell to repair, and that then prompts that cell to trigger cell death. And the most common forms of radiation for most brain tumors, and especially craniopharyngioma, is some form of a linear accelerator or a LINAC. And some of the brand names that some people may have heard of are CyberKnife or a TrueBeam device. Many of you may have heard of a gamma knife, which is a different form. It uses gamma rays, which are higher energy than X-rays. And then more recently, proton beams, and there's different forms or different generations of proton beams, some of which are better than others. And there are advantages and disadvantages to each of these forms. So probably the most common is this fractionated conformal, and the most well-studied is this. And so when we talk about dosing in a minute, we're going to talk about the advantage here. Protons are very expensive devices to set up. It's not available everywhere, and we have limited long-term follow-up on the use of protons. Gamma knife radiosurgery, we have more experience with. It's been around since the late 60s, but there's pretty convincing data that radiosurgery is more harmful in terms of the hormone function of the pituitary than fractionating, meaning breaking the treatment up into much smaller treatment sessions, as opposed to radiosurgery where the entire dose of energy is delivered all at once. And so the most common radiation treatment plan is a dose of 54 gray, gray being the unit that we use to measure the dose in energy of radiation that's being delivered, broken up into 30 fractions. So what this really means is 6 weeks of treatment, 5 days a week, with an MRI or at the very least a CT being done at the end of each week of treatment. And the reason we do this is that despite the radiation, cysts can get enlarged, and sometimes as a result of the treatment, cysts will grow as part of the inflammatory response to the delivery of radiation. And so sometimes treatment needs to be interrupted to deal with dramatic cyst enlargement or managing hydrocephalus if that's developing. And again, we want to catch that before it develops rather than after it becomes symptomatic and problematic. And there are a lot of adverse events associated with radiation, just like there are adverse events associated with surgery. I mentioned the cyst enlargement. Visual deterioration that can be due to direct compression from a cyst, development of hydrocephalus, or radiation effects on the eye nerves. The eye nerves are very, very sensitive to radiation and are what we call a dose-limiting structure. So when we plan radiation, we have to basically plan around those nerves and make sure that we don't deliver a damaging dose of radiation to the optic nerves. Regardless of the form of radiation, after about 5 years, you have this rapidly increasing risk of anterior pituitary failure if you haven't experienced, or the patient hasn't experienced it already. And then you can develop a cognitive decline, especially in patients under the age of 7 years at the time of radiation. And it's also dependent on the total dose to temporal lobes. So this is a dose plan from a proton treatment. And you can see they're coming in from above and from the sides to try to avoid the optic apparatus. The problem is that deposits a lot of dose in the temporal lobes. There are newer forms of proton beam called pencil beam scanning, which greatly reduce this. But this is one of the advantages of breaking it up into smaller fractions, is that this dose to the temporal lobes is lower. And then anywhere where there is a hot spot or a high dose deposition that's normal tissue, there's the possibility of radiation damage to normal tissue, or what we call radiation necrosis. The evidence favoring the use of radiation after surgery is very convincing. So the two largest series, one is out of UCSF and the other is out of what's called the SEER database, which looks at surveillance of all patients in the Medicare Medicaid system, and that includes children who are on some of the CHIP plans, looking at their overall survival based on diagnosis. And so if you look at the three curves, the top curve in every series in terms of survival, both progression-free and overall, is always this subtotal resection plus radiation therapy. And when we look at overall survival in the SEER database, the same is true, that it favors subtotal resection plus radiation, and the resection is an important part of it because radiation alone falls off very quickly. It's not shown on these curves. So if we look at all the large series out there with follow-ups anywhere from 2 years to 10 years out, gross total resection alone, we know there's a wide range there. But the progression-free survival, when you look at subtotal resection plus radiation, tends to cluster on the higher end in the 70 to 80% range, and then significantly better than resection alone without radiation, which is a progression-free survival of only 30 to 40%. So in summary, sort of standard of care and best evidence right now is that maximum safe resection is still considered first-line treatment. That may be a gross total, that may be a subtotal, and that's something that has to be individualized for each patient. If there are large cysts, it may require implantation of an Ommaya, and if there's hydrocephalus, it may require shunting to manage. With radiation, there isn't a proven difference in terms of the ability to prevent progression of the disease between the different modalities, but there is some evidence favoring LINAC, which is where we break it up over 30 sessions, in terms of maintaining endocrine function longer. And overall, the outcomes for subtotal resection with radiation therapy is just as good, if not better, than gross total resection with a lower morbidity. So that means less negative side effects just from the treatment alone. And then oftentimes we may delay radiation, and we don't necessarily have to radiate right away. So in kids, we can do the subtotal resection and then delay radiation until there's growth, sparing them radiation a little bit longer. There's really no difference in the survival either progression-free or overall, versus radiating up front right after surgery. Really, the only role for chemotherapy is putting it into the cyst in some cases to control growth of the cyst, but there's no role for systemic chemotherapy in managing these lesions. Really, medical therapy is focused on hormone replacement therapy done under the direction of a neuroendocrinologist to try to maintain quality of life, maintain development, maintain fertility. I just want to briefly introduce everybody to our team here at Swedish. Like most of the pituitary centers of excellence, we have a multidisciplinary team consisting of neurosurgery, ENT surgery, radiation oncology, neuroendocrinology, neuropathology, neuroradiology, neuroophthalmology. And for those of you who want some more information or want to make contact to ask any clinical questions, here's the clinical intake information. I appreciate your attention today and happy to take any questions.
Excellent presentation. Thank you so much. We do have some questions. What do you do when post-operative patient has central fever?
So the question is about patients who develop a condition called central fevers, which goes back to what I was talking about earlier in terms of the role of the hypothalamus in managing temperature regulation in the body. And first of all, if somebody has had surgery recently, it is a diagnosis of exclusion. That means that the care team is obligated to make sure that there aren't any infections anywhere or any other source of fever, because there's no test that can diagnose it. Once that diagnosis has been made and infections or other complications have been excluded, central fevers are typically managed with either Tylenol or indomethacin in a scheduled fashion, and those medications disrupt some of the molecular signaling pathways involved in mounting a fever. But unfortunately, there's no way to put anything back that's going to cause temperature regulation to function normally again.
Okay, thank you. Do you prefer to use ultrasonic aspiration to prevent hypothalamic trauma?
So the question is about some of the devices that we use at the time of surgery. And I showed one example of a device that draws tissue into it and cuts it. Another is use of ultrasound to morcellate the tissue, basically like a jackhammer, causing it to shatter, and then suction it up. I think part of it is that there's frankly a role for both of those devices. Secondly is that in some ways it's a bit of the surgeon's choice of what they're used to using. There are nuances to using both devices. And just like any other tool, the more you use it, the more comfortable you get with it. I think that either device used incorrectly is capable of damaging any of the surrounding tissues, whether it be the hypothalamus, the optic nerves, or the blood vessels. And I haven't seen any convincing data that there's one that's dramatically better than the other. One thing that I favor the device I tend to use over the ultrasonic aspirator is the ultrasonic aspirator delivers a lot of energy in the form of heat to the surrounding tissues. And even if you don't structurally disrupt them, that heat can cause dysfunction of the surrounding tissues also.
Okay, thank you. There's a couple of questions about whether this webinar will be available for viewing later or if we would be sharing the recording. It will be available after it's edited on our website. It has been recorded and there's a little bit of editing and converting that needs to be done, and then it will be on our homepage at pituitary.org. Next question. I recently completed a clinical trial at MGH with BRAF inhibitors, which completely eliminated my tumor. After 14 months, the tumor grew back in the same area, third ventricle. Now I'm trying to find a new solution. Any data on radiation after drug therapy?
So first of all, congratulations on getting into the study. I'm sorry to hear that your tumor's grown back. I am not aware of any data for or against, or what the outcomes of radiation after treatment with a BRAF inhibitor is. Frankly, that treatment is so new for this type of tumor that it's really limited to individual case reports and individual institutional experience.
Okay, thank you. What caused pituitary apoplexy, and what is the risk of tumor reoccurrence after an apoplexy?
Yeah, so pituitary apoplexy is a condition that's typically seen with tumors of the pituitary gland itself, what we call adenomas. And basically what happens is that the tumor grows faster than the blood supply feeding it. And so the core of the tumor infarcts or dies as a result of being deprived of sufficient blood flow and oxygen. And when it dies, it then hemorrhages, and that can cause an acute increase in pressure. So we typically don't see that after this type of tumor or in conjunction with this type of tumor. But just to answer your question, there are a number of reports out there, I don't know the numbers off the top of my head, that with an apoplexy event, if it's a benign adenoma, that may be in some ways the definitive treatment of the tumor, in that it doesn't require any additional surgery or radiation.
Okay, thank you. In your experience, how often has endocrine function returned to normal post-surgery? Is it safe to say that we tend to medicate into dysfunction versus allowing the pituitary to heal and regulate itself?
So good question, and the answers are conditional. So it depends on the type of tumor and what surgery was done. If we're talking about craniopharyngioma, we know that the incidence of dysfunction after surgery is about 50% if the upper portion of the stalk and the hypothalamus were not involved in the tumor. And if the tumor was involved with either the superior portion of the stalk or the hypothalamus, it's virtually 100%. We know some of that from historic studies before we had the ability to supplement hormones and being able to follow these patients out. I think right now, while we could be accused of over-medicating, the negative health effects of being low on hormones are so significant that, frankly, it outweighs the benefits of risking under-treating in an attempt to wait for the pituitary to quote-unquote wake up or recover.
Okay, thank you. Can you share a little more about your experience with bleomycin treatments through the OMIA? This has been a recommendation from my child's oncologist as a next step if the interferon does not work. I'm very concerned about what I've read about neurotoxic side effects of bleomycin. Thank you.
I don't currently, full disclosure, I don't currently treat pediatric patients. We have a separate children's hospital, a separate children's team that manages them. The data for bleomycin, as I mentioned, is mixed. There are a number of side effects, as you mentioned, neurotoxicity being one of them. However, typically prior to doing bleomycin and probably prior to having done the interferon alpha treatment, what we do is we do what's called a leak test, where we'll actually inject a little bit of CT dye into the OMIA to make sure that none of the material that's going into the cyst can get out to the surrounding tissues. And if the leak test passes and there's no leakage of contrast, then bleomycin is relatively safe and has a much longer track record of usage than interferon alpha does.
Thank you. Do you use vasopressin immediately post-operative and regulate it, or only if you have hypernatremia in cases of diabetes insipidus?
Right, so vasopressin is the hormone that your body makes, and also the medication form that we supplement to help regulate the salt and water balance in the body. and it is the definitive treatment for diabetes insipidus. Every team and every unit that cares for these patients has a slightly different algorithm. What we tend to do here at Swedish is initially we simply monitor the urine output and the serum sodiums, and we don't necessarily treat until the patient is hypernatremic, meaning that their salt blood level is higher than normal. And even then, we typically treat intermittently until we're convinced that people are going to need to be on scheduled doses. So we'll go a day or two with treating as needed before scheduling the medication.
Okay. I was officially diagnosed with a prolactinoma about 4 years ago. The tumor has grown to about 7 millimeters. Carbergoline has not worked, and my quality of life has degraded. My current endocrinologist refuses to entertain the idea of surgery. I have met with a neurosurgeon and am getting another opinion, but I'm wondering if there is another option.
So for Carbergoline, there are 2 medical therapies available. I'm sorry, for prolactinomas, there are 2 medical therapies available. There's Carbergoline, which is the first-line treatment, and then there's bromocriptine, which is an older version of the same medication that's dosed daily instead of weekly or twice weekly. Some people fare better with the older medication. I don't know if the quality of life is due to side effects from the medication or hormone dysfunction. As far as surgery goes, if the side effects of the medications are what's driving the majority of your negative experience, then intolerance to the medication is a surgical indication. If you're not responding to any of the medications and there are other hormone problems that need to be dealt with, then a combination of medical therapy and or chemotherapy, and or surgery can be done. The other alternative, though, would be radiation. And I don't know if you've discussed this with your team or not, but whether it's fractionated or stereotactic radiotherapy or even single-dose radiosurgery, that may be another way to control the growth of the tumor, keeping in mind that radiation at about 5 years has a greater than 50% chance of causing other hormone losses besides the initial one.
Okay, thank you. Are there, to your knowledge, any medications being developed that would shrink craniopharyngiomas?
So one that we're studying right now is that BRAF inhibitor for the papillary subtype. We have a molecular target, the beta-catenin target for the adamantinomatous. There are small molecule inhibitors that are targeting that pathway, what's called the WNT pathway, which is active in some other cancers, but nothing that has gotten to the level of a clinical trial.
Okay. Follow-up question to the previous one. A leak test was done before interferon treatment on my daughter, and there was no leak. Would you recommend another leak test before starting Bleomycin if we decide to go that route?
I don't think that it's necessary if they've done one before the prior therapy, and this therapy has been tolerated very well. Unless there was some surgical episode or some other event, there's really no reason why it would be a problem. And one of the things that we see both with interferon and bleomycin and P32 is that the treatment tends to firm up or thicken the walls of the cyst. They actually get stronger and more firm as a result of the treatment.
Okay. Is there any evidence if radiation goes better in
Adamantinomatous?
Yes, that, or papillar.
So there's a little bit of evidence. The bigger issue is whether or not the tumor is cystic. So what responds better to radiation is the very solid portion or portions of the tumor, whether they're adamantinomatous or papillary. The cysts tend not to respond, and in fact, as I mentioned, sometimes can get a little bit bigger during the course of radiation as opposed to shrinking.
Okay. How do you determine whether radiation or surgery is the best option?
So again, it depends on the type of tumor. It depends on where exactly it is. It depends on how large it is and other structures that it's invading. If we're talking about a craniopharyngioma, all things being equal, the data is very, very convincing and supportive that a maximum safe resection followed by radiation is the best treatment. That surgery alone, if it's not a complete or gross total resection, and or radiation alone without any surgery, those are subpar compared to maximum safe resection with radiation to follow.
Okay. And is radiation ever used in addition to gross total resection?
The only time that you would consider radiation after a gross total resection is if there is delayed evidence of a recurrence or a regrowth. So something that you didn't see on the initial postoperative MRIs, but months, years later, we continue to follow these patients, and sometimes there can be a regrowth. And that might be a situation where you would consider delayed radiation as opposed to a redo surgery.
Okay. Do you have any suggestion how to prevent bleeding intraoperatively for prolactinomas, since that it's very easy to bleed? Thank you.
So there's bleeding anytime we operate, and it can be from the tumor, it can be from normal tissues. There are some things that we do routinely on every case and adjuncts that we have available, both in terms of instruments and medications that we can either give through the IV or apply directly in the operative field to help maintain hemostasis. When you're talking about bleeding from a tumor itself, sometimes the most important and most judicious thing to do is to simply complete the resection of the tumor. And the tumor will stop bleeding once it's been taken out and disconnected from its blood supply.
Excellent. Thank you. Looks like that is it. Oh, how many times have you seen a cranio recur?
Unfortunately, more than I'd like to admit. You know, as surgeons, we like to think that we can take these things out and they go away. But the recurrence or progression for craniopharyngioma is above 50%, even with gross total resections.
Does the likelihood of regrowth lessen as a patient passes the 60-year point for papillary tumors?
So the 60 years of age just refers to the time at diagnosis or onset of the tumor. Biologically, it doesn't have anything or any impact on the recurrence of the tumor if they've been diagnosed and or treated with one previously.
How important is it to spare the stalk in the craniopharyngioma operation?
So I think most surgeons would agree that it depends on the configuration of the tumor and whether or not you're going to be able to get a gross total or a near total resection and not injure or remove the pituitary gland itself. So if we're going in and based on what we see on the imaging and what we see at the time of surgery, there's no tumor in the gland itself, meaning no tumor below the diaphragm, and we think that we can separate the tumor off the stalk, leaving a connection between the brain and the stalk, then we try to do it. If there's tumor in the gland and we're taking the gland, then there's no point in trying to preserve the stalk because it's not connecting to anything. If there's tumor invasive of the stalk up into the hypothalamus, we will often sharply divide the stalk just below its insertion into the hypothalamus to try to get as much tumor as we can without getting into the hypothalamus. But even then, with preserving the stalk, it's only a 50-50 chance that hormone function is normal in the sense that people don't need supplementation.
Okay, thank you. Which do you think is the main cause of mortality? For us, it was hypothalamic syndrome in Peru.
I think everybody would agree that in modern series, the biggest impact is injury to the hypothalamus and development of hypothalamic syndrome, especially in terms of the outcome of patients the longer they survive.
Okay, excellent. Any more questions? Looks like we're getting to the end of the questions. Excellent presentation and excellent questions also. Dr. Litvack, thank you so much for taking your time out today to do this. I think
all right, well, everybody have themselves a good afternoon and a happy set of holidays, whichever ones you're celebrating. And again, I thank you for the opportunity.
Thank you, you as well. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you've missed any of it, as I mentioned before, it has been recorded. After it gets edited, it will be available on our website. There's going to be a brief survey after the presentation. Please fill it out to help us get you the information that you're looking for. Thank you for joining us, and everybody enjoy the rest of your day. And thank you again, Dr. Litvack. Take care.